Hi, it's Rob Fitzgerald again. Welcome back to Quick Hits in Lab Medicine. We're going to spend about 20 minutes talking about serum protein electrophoresis and its companion diagnostic immunofixation electrophoresis. Our objectives are to talk about how we use electrophoresis in the clinical laboratory, how to interpret basic electrophoretic patterns, and how we combine SPEP, serum protein electrophoresis, with IFE, immunofixation electrophoresis. So this is a technique for measuring bulk proteins. If you're interested in measuring an individual protein, we typically use an immunoassay and we get a quantitative value. SPEP gives us sort of a broad panel of proteins, and we're looking for proteins that have milligrams per deciliter concentration, so fairly high concentrations. It's a screening test, most often used for multiple myeloma. But it does pick up some other abnormalities that, if you see it, you should be aware of. Typically, if we find an abnormality on an SPEP, we're going to follow that up with an IFE. And we're going to go through about what both of those means. And as I said in the beginning, if you're interested in a specific protein, for example, one of the things that shows up is alpha-1 antitrypsin deficiency. And by SPEP, you can identify an alpha-1 antitrypsin deficiency, but you don't really know how bad it is. And so you would follow that up with a quantitative immunoassay to figure out how much alpha-1 antitrypsin you still have. This is an example of on the bottom we have an example of an SPEP, or serum protein electrophoresis. So it's very simple. This starts out as a gel. You take a couple of microliters of serum, you insert that into the gel, you put the gel in a buffer, you put electrodes across it, and the proteins migrate. The proteins aren't visible until you stain them, and so you stain them with Kumasi blue or some other type of a general protein stain. And what happens is that albumin is negatively charged, so it's going to go towards the cathode. Immunoglobulins are positively charged, and so they're going to go towards the anode. And so we've separated out albumin. This faint band is alpha-1 proteins. Alpha-1 antitrypsin is one of those proteins. This band is alpha-2. This is beta-1, beta-2. They used to coelute. We've gotten better gels and we can resolve them. Transferrin and C3. And then the gamma region, which are immunoglobulins. And so what we're looking at here is an electrophoregram that's derived from this SPEP. So essentially, a densitometer comes along, it's reading a background, it sees this intense stain, we get this peak for albumin, comes back down to normal. We see this faint peak for alpha-1, so we get this alpha-1 bump, and all the way on down. And so we might see it as an electrophoregram, and in the laboratory you might want to go back to the original SPEP to look at that very carefully, because sometimes you can get artifacts due to the densitometer tracing. So again, another picture of an SPEP. The most predominant protein in serum is albumin, so we get a nice big fat protein for albumin. Our alpha-1 proteins, alpha-1 is again alpha-1 antitrypsin, alpha-2, there's macroglobulins that bind drugs, there's alpha-1 proteins that also bind drugs. Beta-1 is typically transferrin, and that's our iron binding protein. That's where iron is bound in circulation. C3 is a complement, part of our immune cascade, and then the gamma region. And in particular, we're really interested in the gamma region, and we want to see what we call polyclonal immunoglobulins. That's a normal finding. You should have a variety of immunoglobulins, and you should get sort of diffuse staining across there. If you do get an abnormal SPEP, we follow it up with immunofixation electrophoresis. And immunofixation electrophoresis is very similar to an SPEP. And in fact, the first lane is exactly the same. So this first lane is the same thing as a serum protein electrophoresis. For immunofixation, instead of spiking it once into the gel, we spike that same patient sample in the electrophoresis lane, in the IgG, in the IgA, M, kappa, and lambda light chain lane. So for a total of 6 different times, we sample that single patient sample, we put it into this gel, we migrate it, and we stain it. And very similarly, should be the most predominant protein is albumin. This is our alpha-1 peak. This is our alpha-2. This is beta-1 and beta-2. They're not quite as well resolved. And then this is our immunoglobulin region. And what you can see in this immunoglobulin region is that we have what we call a monoclonal protein. We have a very intense staining that's tightly packed together. That's monoclonal. So basically, albumin is a monoclonal protein. And if you're concerned about if you have is a protein monoclonal or polyclonal in the gamma region, that's the immunoglobulin region, you can look to see how wide is it relative to albumin. And if it's about the same width as albumin, it's a monoclonal protein, and we're concerned about that. Monoclonal proteins can indicate cancer. Multiple myeloma is the most common, followed by Waldenstrom's. And then a variety of other conditions. But we're concerned whenever we see a monoclonal protein. And so this patient sample was probably screened by SPEP. They found this monoclonal protein and they wanted to figure out which one it was. And so that's what IFE does. It tells us which immunoglobulin is present. And basically it works by, so here we stain for all proteins. In this lane, we essentially just stain for IgG. And so in this lane, just IgA, just IgM, just kappa and lambda light chains. And so there are typically 5 different types of immunoglobulins, G, A, M, D, and E. But really from a multiple myeloma perspective, G, A, and M by far constitute the vast majority of monoclonal proteins. So we're just really focused on G, A, and M, and we want to see, do they have corresponding kappa or lambda light chains? And so the interpretation of this immunofix is a monoclonal immunoglobulin that happens to be IgG with kappa light chains. And so why is that important? So this really rules out Waldenstrom's, because Waldenstrom's is a lymphoma and it is IgM class. So this is a fairly intense band. We don't know if it's multiple myeloma yet. We need to look at the patient, and we'll talk about that in a second. So this is clearly an IgG lambda monoclonal protein. So as I indicated, the most often reason for ordering an SPEP is to rule out multiple myeloma or to be concerned about Waldenstrom's. There are other things that show up, so congenital deficiencies. So if you see sort of a flat line in the gamma region, that could be due to congenital deficiency, gamma-globulinemia, where you pretty much have a flat line. Those would typically be present at birth. You could also get secondary hypogamma-globulinemia, so you might have some gamma globulins, but they would be below the normal range. So protein-losing conditions, nephrotic syndrome, things like that. Malignant lymphomas or leukemias, multiple myelomas that are non-secretory. So again, multiple myeloma really is a bone cancer where you have a B cell type that has really proliferated and taken over the bone marrow. Most of them are secretory, so they're secreting G, A, or M, but you can have non-secretory, and in that case you might have either hypogamma-globulinemia or agamma-globulinemia. The difference being agamma-globulinemia, you pretty much have 0 immunoglobulins versus hypo is just a lower amount. When we're looking at the gamma region, the first thing that we do is say, is it monoclonal or is it polyclonal? And again, polyclonal happens when you have a variety of different types of immunoglobulins. And in this case, hyperimmunoglobulinemia or hypergamma-globulinemia means an elevated concentration of those. And so we're going to have a big wide peak for polyclonal. We're going to have a short narrow peak for monoclonal. So chronic liver disease, inflammatory conditions cause this. Infections, certain malignancies are inflammatory, so you get a hypergamma-globulinemia, some autoimmune diseases, and a variety of other miscellaneous conditions. But again, we're trying to differentiate monoclonal from polyclonal and then take it from there. So monoclonal immunoglobulins, we call them M proteins. Some people call them paraproteins. Those are all the same thing. So a monoclonal protein, an M protein, and a paraprotein, or sometimes P protein, those are all the same thing. It's one cell line that's cancerous and has taken over and is jacked up the amount of immunoglobulins from that specific B cell. So probably the most common, or from a pathology perspective, the most common would be multiple myeloma, followed by Waldenstrom's. And so main differences there are multiple myeloma is a bone cancer, Waldenstrom's is a lymphoma. And so on bone biopsy, they're going to look very different. And in Waldenstrom's, that's sort of restricted to the IgM class. Whereas multiple myeloma can be G, A, or M. And I think it follows in that order. G is most prominent, followed by A, and then M. You can also have MGUS, monoclonal gammopathy of undetermined significance. And basically, those are typically lower, smaller amounts of monoclonal proteins without the clinical symptoms. They do have a higher preponderance to transferring into multiple myeloma, so those patients are going to be required to be followed and monitored a bit more closely. And then you can have small monoclonal proteins and infectious processes, but typically they go away, so they're not a stable finding. So this is what a normal bone marrow or population of immunoglobulins look like. You have a whole bunch of IgGs, A's, and M's with a mixture of kappa and lambda light chains, and so in circulation you have both intact immunoglobulins as well as free light chains that really aren't shown there. As compared with myeloma, so instead of having a variety of different cell types, we have a single clone. It's a monoclonal that's producing a single immunoglobulin. And so you're going to see, increases of this in circulation, and in fact you'll also see increases of the light chains that would be in circulation. So my presentation today is primarily focused on immunofixation and SPEPs, but serum free light chains are an essential component of this workup as well. And so basically serum free light chains are an immunoassay to quantify how many circulating light chains you have. And what the ratios are. So basically you're looking at both kappa and lambda light chains. You get a quantitative amount, and we look at both concentrations and ratios. And so if you have a monoclonal that's producing too much, you're going to have an elevation of one of the light chains. Your ratio is going to be thrown off, and that would be an indication for a closer look at that patient. It's also used to follow therapy. So if you're trying to suppress that bone marrow that's producing the monoclonal protein, you can follow that by quantification of the serum-free light chains. So these are the 5 classes of immunoglobulins. For multiple myeloma, IgG is the most common, followed by IgA and IgM. D and E are quite rare. So the diagnosis of multiple myeloma has a monoclonal protein. They would typically do a bone marrow biopsy, and our anatomic pathologists are going to look to see what percentage of the cells are plasma cells, and typically greater than 10% is consistent with multiple myeloma, along with a finding of CRAB. So that's our acronym. C for hypercalcemia. R for renal. These immunoglobulins are damaging the renal. They're depositing in the glomerulus, and they're damaging renal function. A for anemia. Basically, you have replaced your bone marrow with this monoclonal cell line, so you're not synthesizing red cells. And you get bone lesions because oftentimes they're osteolytic. So the characteristic bone lesions on X-ray, they call them punched out lesions. So they're a translucency in the bones. So multiple myeloma would be a combination of all of those. So if you just have a monoclonal protein, that might be MGUS. If you have monoclonal protein plus plasma cells, that might be what they call smoldering Multiple myeloma is sort of in the background, but is going to have a worse prognosis than MGUS. And if you have all three, you have multiple myeloma. And so any of the findings in CRAB make that diagnosis. So this is what an SPEP looks like in health. So again, our main protein in serum is albumin, alpha-1, alpha-2, beta-1, beta-2, and then this polyclonal immunoglobulin region here. So, and you know, we give the normal ranges, and all of those are within the normal range, so that would be consistent with a normal SPEP. This one is concerning. Again, we have normal albumin, alpha-1, alpha-2, beta-1. We've got this extra peak in between beta-2 and gamma, and that looks like a monoclonal protein. So that's very concerning. And so we would follow this up with an immunofixation. And when we did immunofixation on this patient, this peak did not show up in G, A, or M. And in fact, as it turns out, this was a serum sample. I mean, this was a plasma sample. And so this is essentially, this next pattern is interesting because we see a normal albumin, alpha-1, alpha-2, beta-1, and we see this extra peak between beta-2 and gamma, and that looks like a monoclonal protein. So we're concerned about that because it's a narrow, it's not broad like this total gamma region, but it's a single spike. And so we're concerned that this could be either MGUS or it could be multiple myeloma. And we figured that out by doing an immunofixation. And so when we did an immunofixation on this patient, there was no monoclonal peak showing up in the G, A, or M, kappa, or lambda regions. And so as it turned out, this was not a serum sample, but this was a plasma sample. And so this is really fibrinogen. And this is due to the fact that someone swapped the tube. So they collected a plasma sample, then they poured it into a serum sample. The lab received it as a serum sample. We thought it was serum. We ran it, and we got this apparent monoclonal protein that was not an immunoglobulin. And so basically, we redrew that patient, correctly collected a serum sample, and this peak went away. And so that's really a pre-analytical artifact that we try to avoid. So that monoclonal looking protein, it was in fact a monoclonal protein, but it was not an immunoglobulin. It was fibrinogen. And so we avoid that by collecting the proper specimen. This is a protein pattern, again, albumin, alpha-1, alpha-2, beta-1, beta-2, and you'll notice that the alpha-1 and the alpha-2 are quite elevated compared to what normally is in the normal pattern, and we call this an acute phase response. And so this is an inflammatory response. We talk about it as an acute phase, but acute phase also happens in chronic conditions. So for example, cancer causes this pattern, and so that's something that's been going on for years. It's not really acute, but these are what we call acute phase proteins. Albumin is a negative acute phase protein, so it goes down a little bit, but alpha-1 and alpha-2 both go up. And so that's how we would interpret that pattern. This is a pattern of chronic inflammation, and so you'll notice that, so here's our normal gamma globulins. This one is elevated, so our gamma is bigger than our beta peaks, and this is consistent with chronic inflammation. So it's a polyclonal hypergamma-globulinemia. This pattern is not showing up very well on this slide, but basically if you look at the quantitative results, you'll notice that the alpha-1 is low, and this is an alpha-1 antitrypsin deficiency. So instead of having a normal peak here, we sort of have a flattened off response, and this would be an indication to follow that patient with a quantitative alpha-1 antitrypsin immunoassay. If that's low, then oftentimes they will genotype that patient to figure out which genotype they have, because many times they can be low but still not pathologic. This is a pattern of hypogammaglobulinemia. So we don't have our normal increase in our gamma globulins, and they sort of have just trailed off. So you do have some immunoglobulins in this patient, but they're below normal, so we would call this hypogammaglobulinemia. This is an interesting pattern that we see, and it's not so striking until you start looking at the quantitative numbers. Albumin is quite low in this patient, and we have this big increase of alpha-2, and we would call this nephrotic syndrome. And so essentially what's happening in nephrotic syndrome is that you're losing albumin through your kidneys. So your kidneys have become leaky for proteins that they shouldn't. Albumin is leaking out. You have hypoalbuminemia. And you're making that up, so you're losing albumin. Your albumin is low, and you make that up by increasing these other bigger proteins. This alpha-2 macroglobulin has a molecular weight of like 1,000,000. So it's this huge protein that doesn't leak out and helps maintain your oncotic pressure. So that would be a fairly striking case of nephrotic syndrome. You might have picked that up by just doing, looking at the patient by doing a basic metabolic panel where you saw hypoalbuminemia, and then if you followed it up, you would find this pattern. This pattern is an example, again, of a polyclonal hypergammaglobulinemia, and this is a specific kind because we don't see a decrease between the beta region and the gamma region. We call this beta-gamma bridging, and that happens in alcoholic cirrhosis. And so essentially what happens is that IgG sort of comes out across this region. IgG is a little bit more in this area, and IgA tends to be between sort of the beta and the beginning of the gamma region. In alcoholic cirrhosis, you increase your IgA synthesis. Your liver, so that's coming from your gut, which drains into your liver. Your liver is unable to catabolize the IgA, and so you get an increase of IgA. And that IgA is what causes this beta-gamma bridging, and that's fairly diagnostic for alcoholic cirrhosis. So a very good example, clearly this is a monoclonal protein. Its peak width at half height is about the same as the peak width at half height of albumin, so it's a narrow peak. Other concerning features about this SPEP is that you don't have a polyclonal background, and so this is a case where that monoclonal protein has essentially replaced the bone marrow, and this is concerning for multiple myeloma. We would follow this up with an IFE. And so when this was followed up with IFE, it was an IgG with kappa light chains, and we'll see an example of that. This is a little bit more rare case. So we have a monoclonal protein here, and we have a monoclonal protein here. This would be, instead of being monoclonal, this would be a biclonal, and typically it has about the same prognosis. Essentially, you got multiple myeloma twice, and so is one explanation, and really you would have to do an IFE to figure that out and show that these were two different monoclonal proteins. Sometimes IgA shows up as a dimer, and so you could also have dimerized monoclonal proteins. But you would follow that up, and when they did follow that up, there was both an IgA kappa and an IgG kappa, so those were clearly different monoclonal proteins, and this is a biclonal gammopathy. This is another, so here our beta 1, our beta 2 looks funny. It's more elevated than you would expect it to be, and so you don't really know what's going on until you run an IFE. And when we ran an IFE on this patient, there was actually a monoclonal protein that was no longer showing up in the gamma region, but it was showing up in the beta region. And so some of these monoclonal proteins can show up in multiple different regions, and that's why we do an IFE, because it is staining for specific immunoglobulins and will show, if there is an immunoglobulin hiding. So anytime you have an elevated beta region, it's advisable to do an IFE because there might be a monoclonal hiding underneath the other beta proteins. This is another example of a monoclonal protein, and we don't know what it is. When they did an IFE, this turned out to be an IgM, and this is the immunofixation electrophoresis for that patient. If you remember, we put the same serum sample in 6 different lanes. Here, this first lane we stained for total protein. This is albumin, the most abundant protein in serum. Alpha 1, alpha 2, beta proteins, and this is the gamma region. And you can see a monoclonal protein there, and we're trying to identify which class of immunoglobulin it is. It's not IgG, it's not IgA, it is IgM. So that's the monoclonal protein, that's the narrow band, and it happens to have lambda light chains. And so this patient has a monoclonal IgM with lambda light chains, and in fact he had Waldenstrom's macroglobulinemia. Thanks very much for tuning in.